Hi there, everybody. We're just going to wait sort of 10 or 20 seconds, just make sure everybody comes in, and then we'll get started. If somebody could just pop in the chat, just make sure they can hear me okay, that'd be great. Oh. Perfect. Thank you. Cool. Okay, I think we'll get started now. Just a thank you for everybody for joining. We've got a lot of sign-ups as well, and we were just talking before. With it's great to see so many people engaging with us in this as well, especially as things have opened up, and I'm sure a lot of you have got clinics are getting busier and sports reopening. So it's fantastic, and it'll be interesting to see when the pubs open how many of us are still here. So no, it's great that everyone's engaging with this, and we'll keep putting these on for everybody. And a huge thank you for John this evening for joining us. This webinar is in partnership with the AACP, so that's the Acupuncture Association of Chartered Physiotherapists, and John can go into a bit more about his presentation and what he's going to discuss this evening. We will have the presentation for about 45 minutes, and then we'll do a Q&A at the end. So please just pop your questions in throughout the whole of the presentation. As always, the Q&A, put it in the Q&A box, don't put it in the chat box. The Q&A box allows us to, or allows you, sorry, to upvote other questions that you like, and then we will ask the ones at the top first, which would be great. So get the questions in. If you just another bit of housekeeping from me, sorry. Next week we have a webinar with Cardiff Blues. So we've got Josh Adams, who's Welsh international player as well, on that, and the senior physiotherapist, Griff Parsons. And we'll be talking about injuries, injury management, player load within international and domestic rugby, and some of the mental health stuff about getting injured, and coping mechanisms within that. So comms will go out for that tomorrow. So keep your eyes peeled for that and get signed up, because that'll be a really good one. That's next Thursday. And yep, so questions in the Q&A box, that's the key for tonight. We want to make it as interactive as possible. We want to hear as much from you guys as we can do. So again, a huge thank you for John and to the AACP for giving up the time this evening. And yeah, John, do you want to take it away?
Thanks, Charlie. Hi everyone, welcome. Thanks for giving up your time this evening. Seeing there's quite a few participants on there already, which is great. As Charlie said, great if you're getting back into clinic and you're getting back to some face-to-face, and this is where obviously this comes in for you guys. Just a few notes on this. This kind of presentation came about because I get asked a lot of questions about, what's the evidence for acupuncture? How do you use it? What's it all about? And there's lots of different ideas and lots of different thoughts about it. So this is trying to kind of give you an introduction and an encapsulation of some ideas about how you can use it from a neurophysiological approach, as opposed to a traditional sort of acupuncture approach, because I know that different theories sit differently with different clinicians. So I'm going to try and make this as applicable from an anatomical, a physiological and a pathological perspective as much as possible. So I'll tell you a little bit about me, so you know where I'm coming from with this. I've been in physio for the last sort of 25 years. I've been practicing acupuncture, dry needling and various forms of needling for the last 20 years clinically. Got a master's degree in acupuncture way back in 2004. And a lot of people see me as a kind of an acupuncture type physio, but I've got a 30+ year history in prescribing exercise. My foundation is exercise. And when I use needling, it's how it ties in with that. And I'll talk a little bit about that later on. So it isn't just about acupuncture or dry needling. I'm going to use the term needling as a sort of generic term through the presentation probably, but we'll break it down and talk about what different types of needling and what the words mean and so on as well, because people have different ideas about those sorts of things. So for me, as I say, got 30-year history prescribing exercise. I've worked in the NHS, private sector, professional sport. I've been at one university head of a MSc in clinical biomechanics. I've been head of a school of physio at another university. I've lectured in various different areas. I've written courses in cardiac rehab, pulmonary rehab, exercise on prescription, written degrees for universities in sports rehabilitation and so on as well. I've been an external examiner in traditional acupuncture, but I also lecture at medical school to second year medical students and explain some of the physiological mechanisms of acupuncture. So when they become physicians and start prescribing, that it's not an alien idea to them. You know, it's not an abstract concept. So I also teach for a lot of premiership clubs and championship clubs. You may not see those courses advertised because they're pretty much in-house. I teach for the MOD as well. I teach for the Institute of Sport Wales. Teach in the US. I've taught for various members of the Navy SEALs in the US. I've taught for NFL teams, New Orleans Saints in the States as well, and teaching in the Middle East and India and various places. So any questions you've got about any of the aspects of needling, how it fits in with your practice and so on, I'll do my best to answer those and give you some clinical reasoning behind that as well. So feel free to throw those in as we go. Let's crack on with this then. I mean, acupuncture triggers a lot of thoughts in a lot of people. You know, people have got their own preset ideas about what it is and what it isn't. And what I'll do is I'd paraphrase Aristotle on this one and say a sign of intelligence is the ability to entertain an idea without accept it. So all I'm going to ask you to do is to entertain the idea. You don't need to accept it. You don't need to agree with me. You don't need to get on board with me. I'm just going to ask you to entertain the idea. And if you can entertain an idea, and then you can try and apply it either through your thoughts in a theoretical sense or a clinical sense, and maybe see how it fits in with your approaches, you may come to utilize it as well as, and not just entertain it. But keep your minds open, and that's how we learn things, by keeping that idea and the ability to entertain. So a couple of things we're going to be talking about here and give you an idea of what we want to hope to achieve in this session. I'm going to give you a brief introduction to the physiological mechanisms, and we're going to talk about that role, particularly with the treatment of myofascial pain, because that's where a lot of people see it, that's where a lot of people use it. It has got a lot of use in that area and can be very effective clinically. Like I say, I've been utilizing it for over 20 years now in a clinical setting. I'm still clinical after all this time. You know, I split my time pretty much evenly between teaching and clinic, and I'm still developing techniques and treating new things and thinking about new ideas and new utilization for needling techniques as well, and still mentoring under other clinicians who have different approaches as well. Keep my mind open about things all the time. So needling. So if we think about how effective it is, you know, you hear different things, but essentially when we look at the evidence for the treatment of myofascial pain in a primary care outpatient setting, 90% of problems it can be effective for if they're myofascially based. 70% more for sort of nociceptive pain, other conditions. And then when we get down to other pain conditions, perhaps neuropathic pain and so on, it becomes less effective because there are more complex mechanisms in play there perhaps. And these can relate to central effects within the body that we'll discuss a little bit later on. Key things we're going to be discussing in the presentation. We're going to be discussing analgesic effects most prominently, and the local segmental and supraspinal mechanisms for those, and how that fits in with our treatments and our thought processes. I'm going to be talking about the use of filiform needles. So if you're not familiar with needling, acupuncture needle is very different from a hypodermic needle, and a filiform needle, or like a hair-like or thread-like needle, is a very thin, conically tipped needle, so it doesn't have a cutting edge. Very different from a hypodermic. Those of you who know needling know this already, but those of you who are new to it and may have some apprehensions about needling, it doesn't feel like being injected. You know, I always say when I'm teaching to not to preempt needling by saying to a patient sharp scratch, because that's more about a hypodermic and how that cuts in. But a filiform needle is very different, can slide in. You can see there when you look at the measurements on microns, you know, the relative size of the needle, the relative size of human hair and muscle fibers as well. When we're thinking about point placement, and this becomes important depending on the condition, and the question I get asked a lot is, you know, how specific are points? Kind of depends on what you're treating, really. In my mind, in my clinical practice, I think of it as, if you understand your pathophysiology, if you've done a good subjective and a good objective and you narrow down what the problem is, that helps you determine how specific you need to be with needling, because it depends on what you're aiming for and what you're trying to achieve. And we'll talk about the different mechanisms a little bit later on when we've run through the analgesic responses. But things that we're considering when we're thinking about point location will be dermatomes, myotomes, sclerotomes. If you're MSK, you're familiar with those. And if you've got other medical knowledge, you may be familiar with viscerotomes as well. And viscerotomes can be important when we look at some of the other mechanisms that needling can have. When we get into things like treating overactive bladder or bowel dysfunctions and things like that, which are treatable to a greater or lesser degree with needling, that comes down more to sort of viscerotomal responses, which can be useful. Particularly when you look at things like, look at it from a sporting perspective, if you're looking at athletes with bladder dysfunctions and so on. And this could be perhaps your masters female athletes, particularly if they've had children previously, and there's issues with continence, which can be quite common in some sporting activities. So it can be useful in some of those settings as well. Some of the stuff that's not talked about so much, but you actually see clinically. So things to think about with needling response. It's different from a pharmacological intervention. When you look at exogenous treatment, so medications, exogenous, out of the system, medication and pharmacological interventions have often a unidirectional push, in the sense that they're affecting the system in a certain way. Acupuncture doesn't really work like that. Essentially, you're creating trauma and an afferent input by sticking the needle into the tissue, and the central nervous system is responding to that, and it's modulating that response. So as a result, you can get central responses that can affect nervous system, cardiovascular, endocrine system, immune system, autonomic system, and so on. And as I said before, depending on what you're trying to achieve depends on the location and how that location can enhance the effect. It's variable depending on the individual, but also dependent on the location of the point and what you're trying to achieve. So we'll explain that in a moment. Okay, so if we insert the needles locally, the first thing we're going to get is trauma. At the end of the day, you're inserting a foreign object into the body, so you get trauma. The body's response to trauma is always inflammation, and so that's going to give you those 5 cardinal signs of inflammation, which is heat, redness, pain, swelling, and altered or loss of function. Of that heat, that redness, that swelling, those are going to be driven by chemicals pushing vasodilation, such as calcitonin gene-related peptide. We're also going to get adenosine, nitric oxide, bradykinin, neurokinin, vasopressin, substance P, various chemicals being released. But of those vasodilators, that's going to increase the circulation in that area. Now, if we think about tissue healing, one of the things that we need for tissue healing is circulation. That's what it's for. It's for transportation. It's transporting nutrients for metabolic activity. So if we've got damaged tissue, that needs to repair. And if it needs to repair, then we need that circulation to support that. So needling brings that circulation. So the first thing that happens when we put a needle in, get that increased circulation, that can be useful for tissue healing in its primary phase. If we repeat that needling and we come back and we're doing more of a longer term treatment, that CGRP can stimulate angiogenesis, so the laying down of new blood vessels. This again can be useful for tissue healing, depending on the trauma, depending on the state of the tissue. And this way it comes down to understanding what the pathophysiological mechanisms are of the condition you're treating. So have we got trauma there? And if we have, what do we want to do to it? If you want to increase the circulation, put a needle next to it. If you don't put a needle next to it, because that's what it's going to bring. It can also bring the release of nerve growth factor, which can influence wound healing. And the combination of those chemical releases can be beneficial for healing rates. So even before we've looked at acupuncture or needling for analgesia, we could potentially use it for healing. So if you think about any conditions you've got where you've got some trauma there, whether it's trauma to the muscle, whether it's post-surgery, whether it's hematoma, even things like pressure sores. If you think about things that may occur with your some of your para athletes, if they're having to use prostheses, or they're having to use any devices to aid mobility and so on, and under certain loads, can be prone perhaps to damage the tissue, can be utilised in those sort of settings. You wouldn't needle the actual wound itself, you needle around it, and that can stimulate a healing response. Obviously, it's got to be appropriate. We know other contraindications and precautions. We're not covering those in this talk, but that's something that you can investigate if you get into needling anyway, or if you're already in needling, you should already know those. So we'll also get a local analgesic response as well. So adenosine, which is released locally to the needle, can influence C fibre transmission and inhibit the C fibres, and therefore potentially reduce down some of that pain transmission that's coming from the troubling area. We can also influence cytokine release, and nerve growth factor can influence immune response and the neuroprotective effect of cells in that area. Can also influence connective tissue. So you're going to insert the needle, and typically we'd rotate or thrust the needle gently. Rotating the needle creates an effect called mechanical transduction, which causes the tissue to grip to the needle and deforms the local tissue. So that deformation can occur a couple of centimeters around the needle, so maybe 25 mil in radius to the needle, and this can influence the local fibroblasts, which can help with tissue tension and soft tissue healing as well. It's useful for perhaps affecting range of movement and function in muscles as well. So if you're very exercise based, which I think most of us are, and you're looking at something like dysfunction with the shoulder, and maybe you've got overactivity in some muscles and so on. Maybe you've got some tightness in teres major or subscap or something like that, and that's affecting lateral rotation. Needling to alter range of movement can be a very useful thing. Whether it's trigger point needling or not, and people have got different ideas about trigger points, completely understand that, because the evidence is variable in some settings and some aspects of trigger pointing, but can be useful for changing that sort of myofascial effect in the area of the tissue and influencing range of movement. Can also stimulate an inflammatory response, both locally and centrally, and they'll have different effects and can be useful in different ways, depending again on what the pathology is and what you're trying to treat. It also has a cumulative response, which is interesting as well. So one of the things that's noted about repeated needling is you can modify gene expression for opioid production. So essentially, we all have a preset default opioid production kind of like level, and repeated needling, when I say repeated, don't repeat it like all the time, repeating maybe perhaps a 3-day sort of frequency, that you can modify gene expression for opioid production. Now, of course, this is very relevant at the moment, and we'll talk about the new NICE guidelines for chronic pain towards the end of the presentation. But one of the things that's obviously troubling modern sort of society at the moment is the increased use of opioids. And this is leading to issues with increased sensitivity to pain and increased sensitivity to opioids. And so as a result, it's not dealing with the chronic pain sort of epidemic that we've got at the moment. So useful ideas in the way that acupuncture can perhaps modify gene expression in some individuals and restore some of that endogenous opioid production that may be suppressed because of exogenous opioid consumption. And this is optimized about 3 days. So if you're needling, if you want to optimize that physiological response and get a reaction greater than just a single dose response, so a cumulative reaction, so a stepping up of the effect, useful to consider coming back in about 3 days, perhaps, when that is at its high point before it decays. Okay, so that might be a little bit of a daunting slide for some of you, but it's actually an oversimplification of the mechanisms that we really need to discuss. Now, again, I appreciate you guys are going to be all different levels and have all different levels of understanding of pain mechanisms, how they're generated, how they're suppressed, how they're modulated from both spinal cord and higher centers throughout the central nervous system. So what I'm going to give you here is a very simplified model, and I appreciate if you've got more complex ideas, those are fine as well. This just works as a mechanical model to explain rudimentary effects of pain and acupuncture and needling and how that fits in. So I'll take you through this, and it's we'll break it down stage by stage. So if we start with some localized pain, let's make this something like the knee. So if we come down to cell 1 down here, and we see the painful stimulus over on the left hand side of the screen, if we make that the knee and suggest that we've got C fibers transmitting pain up here to the dorsal horn of the spinal cord, and remember we've got dermatomes and myotomes and sclerotomes. If perhaps we think of this as a sclerotome for the knee, the connective tissue of the knee, we can make this around L3 in the spinal cord. But also, when you're thinking about spinal cord, let's say you're thinking about L3, you're obviously thinking about L2 and L4 as well, because you've got intermediate neurons that connect both those layers above and below. So it's never just as cut and dried as a single segment. You know, there's influence in the segments above and below as well. So synapsing from cell 1 here to cell 2, we're going from cell 2 via the spinothalamic tract, where it's ascending via the thalamus up into the cortex. So as it's passing through the thalamus, which is kind of like that gatekeeper of the stimulus there, up to the cortex, once it reaches the cortex, then you've got a more conscious opinion of what's going on with that pain. And if we think of pain from an affective point of view, in the sense that it's quite a subjective feeling, you know, your patients are going to put some kind of psychosocial construct on this, in the sense that they're not going to, you know, experience this pain and turn around and go, well, that's 6 out of 10. You know, they're going to put it on a VAS scale. What they're going to do is they're going to think of it as an influence on their daily activity. So maybe they can't train, or they're struggling with the stairs, or they need to go to the doctor or the therapist or a clinician or whatever. So they'll put some kind of psychosocial subjective spin on this that will be relevant to them as an individual. And that's what we've got to appreciate when we're treating pain. Also remember that the reign of pain falls mainly in the brain. So anything down here isn't really pain, it's just a signal. It's only when it gets here and it's really processed that it becomes something of value to that patient, that individual. What we've also got here as well, stemming from the spinothalamic tract, is we've got a branch running off down here to 8, which is coming to the midbrain, which is going to influence the limbic system and the periaqueductal brain. And we're familiar with the idea that limbic system is involved with emotional responses. And we've just said that much of the pain here is affective in that it's emotional to some degree. When I say emotional, it doesn't mean it's, I'm not dismissing the pain when I say emotional. What I mean is it's got a deep value to the individual. So we've got limbic system involvement over here as well. And again, this is about, feelings and emotions. Pain can be a very emotional thing. So straight away, individuals are involved with that emotional content. But we've got this descending response, and we'll talk about how this descending mechanism occurs in a moment, but we'll come back to this. We'll keep that one in mind. If we come over here and we look at the needle stimulus, and we'll see what happens when we introduce needling into this scenario and see how it plays out. So as we insert the needle, as we said before, the first thing we're going to get is trauma. And it doesn't matter what type of needling you're doing, whether it's traditional Chinese acupuncture, Western medical acupuncture, dry needling, trigger pointing, IMS, and we'll talk about those different types in a moment. It doesn't really matter what you're doing, you're going to get the same thing. You know, there's no Chinese physiology, Western physiology when it comes to acupuncture. So there's no traditional Chinese physiology and Western medical physiology. There's just physiology. So when you insert a needle, regardless of what you're doing, regardless of what needle is, you're going to get the same thing. And what you're going to get is trauma. And trauma is going to bring about inflammation. And inflammation is going to bring you heat, redness, pain, swelling, and altered function or a loss of function there. So if we insert the needle through the tissue, and let's think about 5 layers of tissue there. So we've got skin, we've got adipose tissue, we've got connective tissue or the fascia, we've got muscle, and we've got bone. So here we're inserting the needle down to that 4th level, down into that muscle. And remember, when you get down to that 4th level, you could have multiple levels there. You know, if you're needling up in the shoulder, adjacent to the scapula, You could be needling upper fibers of traps. That could be level 4A, 4B could be elevator scapulae, 4C could be serratus posterior superior, 4D could be iliocostalis thoracis. You don't want to go to the E and the F because they're intercostals, so you want to stay away from those anyway. But you could think about this, different layers of muscle as well. So not just muscle generically, you could be in this particular muscle that's problematic. So we're going to insert the needle. Let's say we get down to that 4th level muscle. And when we insert it there, we rotate it. And we'll use that as our stimulus here. So rotation of the needle will give us mechanical transduction, which is a tension, a deformation, a gripping of the tissue to the needle. This is going to fire A delta fibers in that area, which are going to act as a mechanoreceptor and be responsive to the pressure change caused by the rotation of the needle and the insertion of the needle. This is going to stimulate those A delta fibers, which are a small diameter myelinated afferent. So they have a very rapid conduction rate. The C fibers are non-myelinated, so their conduction rate isn't as rapid, but these A deltas are significantly more rapid. So what they're going to do is they're going to stimulate this, or the needle's going to stimulate the signal. A delta fibers are going to transmit up to the spinal cord. Now, if we put the needle where the problem is, the A delta fibers are going to be in the same spinal segment. So we'll come back to that in a moment. But what's going to be happening here is we're going to get a release of adenosine, as we mentioned. Particularly if we rotate the needle, we'll get a higher level of adenosine. And then adenosine is going to bind to the C fibers and potentially inhibit some of the transmission, which is useful. So we're going to get the increase in circulation in this area. We're going to get myofascial change in the tissue. So that could help initially create tension and then release tension in the muscle. So that could be good for the tissue for healing and mechanical effects. And what we can also get there is that adenosine release, which is going to inhibit those C fibers to some degree. A delta fiber is going to continue to transmit up to here to the spinal cord, where it's going to synapse around cell 6. And here it wants to ascend the anterior lateral tract up to the archionucleus, the higher centers of the central nervous system. But what it's also going to do is it's going to synapse to the intermediate neurons. When it does that, it's going to excite these fibers at 7, and they're going to increase or start to release metenkephalin. And one of the things that metenkephalin is going to do at this level is it's going to inhibit the presynaptic terminal. So when I say inhibit, you know, it may not shut it down completely. It may just slow down the flow or inhibit some of the flow of the synapsing stimulus from the presynaptic terminal to the postsynaptic terminal, from cell 1 to cell 2. And if it's inhibited at this presynaptic state and it doesn't reach the postsynaptic terminal, then the signal isn't conducted in the same way or isn't conducted as significantly. So we get this inhibition here, this presynaptic inhibition, which is also referred to as pain gate or gate control theory, postulated by Melzack and Wall, nominated for a Nobel Prize in the 60s, which they didn't get. And it's been a very fundamental explanation for mechanical pain and mechanical analgesia for decades. So it's been a very useful tool. Melzack and Wall themselves would comment later on that it was significantly more complex than that. But as a rudimentary explanation and an explanation I'm giving you, it kind of works as a model, but significantly more complex than this. What's also happening at this cell 5 here at the dorsal root ganglion is this is sensitizing to the production of opioids as you're needled. I'll come back to this in a moment as well. So this continuing signal via 6 is ascending up here, and it's going up to the midbrain, where again it's influencing the periaqueductal gray, the limbic system, the Rafe nucleus as well. Signals also continuing up to the pituitary hypothalamic complex, where we're getting a response that's descending back down to the midbrain as well. And we're getting the release of beta endorphin in this area. So we have metenkephalin down here. We've got beta endorphin up here in these higher centers of the spinal cord. And what we're getting here is a stimulus via the Rafe nucleus to a descending mechanism via the dorsolateral tract. And it's causing the release of monoamines here and here. Now, these are serotonin and noradrenaline. Now, what serotonin does when it's released in the spinal cord is it excites the intermediate neurons here and increases and reinforces the release of metenkephalin. And as we said before, what metenkephalin does in this sequence is it creates presynaptic inhibition. Now, noradrenaline, very interesting here, being released as well, is also inhibitory as metenkephalin is. Serotonin is excitatory, but the noradrenaline is inhibitory. And what this does is it inhibits the postsynaptic terminal. And one of the interesting things about this as well is not only is it inhibiting those terminals, but it's also not differentiating its spinal segment. So it's potentially released at any level throughout the spine. The ascending afferent gating is occurring in a particular segment, which is why you want to needle where the problem is, so you can share the same segments. By segments, I mean dermatome or myotome or sclerotome, traditionally. But this descending mechanism for noradrenaline isn't differentiating the spinal segment, so this can inhibit pain at a number of different levels, which can be very useful. It's one of the reasons why you can treat a problem and not be in the area of the problem. It also creates an issue when we look at research. So when real acupuncture, which is acupuncture normally in the area, and sham acupuncture, which could be acupuncture out of the area, show very similar results for studies, this could be potentially the mechanism by which it does that, because you don't have to be near the problem to treat it because of this mechanism, this descending opioid-driven response. It doesn't end here though, because what we've also got, if we track back up to the pituitary hypothalamic complex, and we've got this stimulus coming down, but we've also got this stimulus into circulation as well, where we've got a release of beta endorphin and ACTH, which is adrenocorticotropic hormone. So this will modulate the level of cortisol in the body, and so this can influence central inflammatory responses and so on, whether they be autoimmune or so on as well. So if we break it down, we've got local responses, segmental and supraspinal. So these are occurring sort of chemically in the area where we've got tissue healing, we've got local opioid response, we've also got myofascial changes, and then we've got this segmental response, which is a neurologically driven mechanism. And we're getting opioid release in the spinal cord and inhibitory responses. And we've also got this descending opioid effect from the higher centers here in the brain, where we're getting this cascading down and this release of chemical response. Now, a couple of things we'd probably just add into this, going back to that cell 5 again, we mentioned that increased sensitivity in the dorsal root ganglion. This is that response that can give you a cumulative effect of opioid response and a modification of gene expression to some degree, because you get an increased sensitization here. So body starts to sensitize to its own opioids. So it starts to like to create them and a little bit more. And what we've also got here as well in these higher centers is if we're inserting the needles, we may want to leave them in up to about 20 minutes to optimize this descending opioid response to a greater degree. So that can give us some reasoning behind how often we needle, locations we needle, how long we leave the needles in, starts to come from the physiology. When you're looking at clinically reasoning, anything that you do, you know, when we look at studies, you've got bench and bedside studies. So bedside studies are clinical trials with patients in and so on. But you've also got bench studies, and bench studies are physiology-based studies. So those that may be done in a lab and they're looking at chemical responses and so on. And in the absence of bedside studies that you can use for given pathologies, you can always use bench studies to create a basis for clinical reasoning. You know, when you're thinking about any intervention, what you should always be thinking, regardless of whether it's acupuncture, you know, it could be manual therapy, could be exercise, could be any of your interventions. You always want to be thinking about what's the pathophysiology of the problem, what's the mechanism and modality, how do they fit together? If they fit together and have a clear physiological binding in the sense that one can physiologically affect the other, then you've got the basis for a good clinically reasoned argument for why you could use that intervention, even in the absence of significant trials. If there isn't a physiological marrying of the two, then you're really going to struggle to explain why you want to do that. It's like using you know, pro-inflammatory or anti-inflammatory interventions when there's no inflammation present. It really doesn't uphold itself as a clinically reasoned model, you know. So if we just review the reasons we might want to put a needle in, I say this to all the clinicians I work with. I've taught well over 2,000, predominantly physios, but lots of other clinicians as well over the years. And what I get them to do is when they're talking to the patient or when they're treating a patient is think about why you're putting a needle in. What I don't want guys to do is just take a prescription that they've read or they've been taught and just apply it. You know, you always got to be thinking about why you're doing something, whether it's needling, exercise, manual therapy, advice. You always want to be thinking about, what do I want to achieve? How am I going to achieve it? What's the mechanism I'm going to achieve that by? And that will just drive your clinical reasoning all the time. So 5 very quick things to think about when you're thinking about needling somebody. You know, the reasons why. So first reason, wherever you put the needle, you're going to get a local trauma response, you're going to get inflammation, healing response. So excuse me. So when you put a needle in, you're going to get those. So do you want that local healing response? Yes, put a needle in there. No, don't put the needle in there. Put it somewhere else. You'll get a local analgesic response, opioid and adenosine and so on. So that's another useful thing. You know, why you're putting the needle in, get a local opioid response. You will get a myofascial effect, a mechanical response. That can alter range of movement, loading, function. You can think trigger points or just myofascial tightness. Doesn't have to be a trigger point. You know, when there's controversy over whether people believe in trigger points or not, doesn't really bother me, because whether it's a trigger point, whether it's myofascial tightness, the needle will cause both to change. And so whether it is just inherent tightness, you can change that with the needle anyway. So it doesn't really matter if you're differentiating those two so much, providing you're thinking about the underlying anatomy and why you're needling that location. You'll also get segmental analgesia, and I'll note segmental response is there as well. We've talked about analgesia, but affecting things like overactive bladder, you know, by tapping into the S2 visceral tone and the parasympathetic responses to those structures, that can be useful as well. And that's a segmental response, but obviously is an analgesia. And central mechanisms and systemic effects, autonomic regulation, descending opioid response, ACTH. And when we talk about autonomic regulation, that can be sympathetic, parasympathetic effects. So they got talked to a lot of, you know, sporting organisations about, particularly at higher levels, is how to stimulate parasympathetic response in athletes, how to get them to heal and recover, how to get them to sleep. Sleep is just intrinsically important to recovery and performance. It's one of the fundamental factors for improving performance. You have a finite capacity to recover. So if you can't sleep and you can't recover, and sleep is for recovery, and you require approximately 8 hours a day, and an athlete requires more than that, and what we know from the research is they don't get that. Sleep is a predictor of mortality and morbidity as well. So it can be a predictor for all sorts of things. So it's very, very useful. And one of the things that acupuncture can do is modulate that autonomic response, particularly parasympathetic response, downgrade sympathetic reactions, and help with sleep, also help with digestion as well. So central effects there as well, thinking about those sorts of things. So point location, why are points located where they are? Well, it can be because there's convergence and divergences in the tissue. I think of them as areas of sensitivity and reactivity. I don't really think of acupuncture points in a traditional sense. I think of them as relating to the underlying anatomy. And if anyone's interested in that, I've got a number of articles coming out on anatomy and how that relates to points coming out in the near future. Proximity to neurovascular structures. You know, if you're going to have an area of sensitivity and reactivity, it needs to be innovated and needs to be able to respond to that metabolically. So it's going to need the innovation to make it sensitive and the circulation to make it reactive as well. You're also thinking about, you know, the depth of the neural structures, how they pass through the fascia or the foramen. That's relevant as well, because where they exit, they become more accessible to needle. And often a lot of the needling I talk about in the peripheries is perineural. So we needle close to the nerve to get either a local, a segmental, or a central effect. I'm thinking about sensitive structures and motor end plates, so neuromuscular interfaces, points like that as well. Connective tissue can be abundant in fibers as well. Just give you a quick briefing on different types of acupuncture. So here we've got traditional Chinese acupuncture, Western medical acupuncture, dry needling, trigger point needling. One of the things you'll find is these three terms, Western medical acupuncture, dry needling, trigger point needling, get used interchangeably. And there's a bit of an issue with this, I think, because it relates to not the needle or not the technique, it relates to scope of what you're treating, really. So if we start with traditional Chinese acupuncture, essentially you can treat anything at all. Doesn't really matter. Pretty much treat anything. And so that's a very, very large scope. So when we break this down, what is Western medical acupuncture? Well, Western medical acupuncture is reverse engineered Chinese acupuncture. You take Chinese acupuncture, you copy it, you unpack it, you explain how it works from a physiological perspective, you do some research, you get some studies, and you use those to inform practice and medicalize it in a sense. That's what Western medical acupuncture is. So that's predominantly what I teach, and the AACP does, and the majority of physios do. Then you've got dry needling. Well, traditional Chinese acupuncture, you needle all over the body. Western medical acupuncture, you needle all over the body. Even if you've got a problem in a certain area, you may needle distal to that. Dry needling, you only needle in the area. So Western medical acupuncture and dry needling aren't the same. So dry needling, you just needle in the area, but you needle the muscle or the connective tissue. If you were needling the shoulder, you wouldn't needle the hand as well. But traditional Chinese acupuncture and Western medical acupuncture, you needle the shoulder and the hand, right? For different reasons. Traditional Chinese acupuncture would be about chi flow. Western medical acupuncture would be about reinforcing the spinal segments, or about supraspinal effects, stimulating peripheral sympathetic response. So dry needling will just be in the area of the problem. What's trigger point needling? Exactly what it says, needling trigger points. That's all it is. But dry needling isn't necessarily the same as trigger point needling, because the scope gets smaller and smaller and smaller. Because trigger point needling, you're not going to be needling connective tissue. You're just going to be needling the trigger points in the muscle. Whereas in dry needling, you may also be needling the connective tissue around the knee, the shoulder, the ankle, and so on. Now, different people will have different ideas about what these things are, but it comes down to really, what is the scope? You know, what's your scope? What are you thinking about mechanisms? What conditions are you treating? How are you treating them? Trigger point needling isn't really a different type of needling. It's just a technique, you know. And dry needling is like Western medical acupuncture, but you remove all the peripheral needling. So Western medical acupuncture is what we predominantly practice as physios and what I predominantly teach. So what's the difference from these from a you know, anatomical perspective? Well, as Melzack suggested, Melzack and Wall, significant correlation between trigger points and acupuncture points. Dorsha suggests even higher, and that depends on how you define myofascial pain. Big correlation between trigger points and sensitive points and acupuncture points, and big correlation between the intersections of connective tissue as well, and those different connective tissue layers and points, as I mentioned before. So if we quickly look at the evidence, you know, if we look at this publication, this is the National Institute of Health Research, June 2017, their Signal publication that went out to general public. A couple of interesting things here. One of the ones I always draw attention to is this one, drawn from 140 trials of high quality trials reviewed in a systematic review. Acupuncture was better than standard care for osteoarthritis and knee pain and outperformed exercise and weight loss. It's an interesting thing. As an exercise specialist, I wouldn't have thought that were the case, but that's what the study shows, and there we go. Improved quality of life, shows its greater effect than sham, and so on. So interesting stuff there. Another question that people say to me is they ask about evidence, and they say, well, trials have never got any numbers in. Well, there's 21,000 here, and acupuncture was superior to sham and controls, effective for the treatment of chronic pain, with effects persisting over time, and effects well beyond those of placebo. Interesting. So we look at the NICE guidelines from 2 weeks ago, just came out around the 7th or the 8th. Consider offering acupuncture or dry needling for chronic primary pain, delivered in a primary care setting, maximum of 5 treatment hours. So if your treatments are 20 minutes, it's 15. If your treatments are 10, that's, sorry, if treatments are 30 minutes, that's 10. 10 treatments, and NICE say that you can determine how long your treatments are yourself as a clinician. Treatment bands 5 to 7, or the equivalent of in any sort of setting. NHS and NICE recommending that. So interesting to see what happens with that in the coming months. Things you need to consider whenever you're needling. It's an invasive procedure. Respect the patient, respect the anatomy, respect the technique. If you deviate from any one of those, that's when your problems occur. I work as an expert witness in legal cases when things haven't gone as well as people would hope. So give evidence in court, and what normally happens is people have misunderstood a technique, perhaps as it relates to anatomy, and therefore have injured the patient. So respect your patient first, then respect the anatomy, and the technique is the final thing. Don't put technique before anatomy. If your technique is great, but you're in the wrong place, you're gonna have a problem. So always thinking about that anatomy and basic procedure. I teach some courses in anatomy and so on, if anyone's interested in those. Let's just look at clinical reasoning before we wrap this up, because that's very important when it comes to needling, rather than just sticking needles in people. What you've always got to do is ensure that there's non-malevolence and beneficence. So first do no harm, then do some good. And when we think about the 3 pillars of evidence-based practice, people only quote the first one normally, which is current best available evidence. But you've got to understand there are 3 equal pillars to it. You've got the best available research or external evidence, and that's published trials of any type that you can get your hands on for that condition. So it's not all about multi-center RCTs. It's about whatever is relevant for that condition and what's available. We've also got clinical expertise and experience, which is you as a clinician, and that's of huge value as well. And obviously, let's not forget why we're in this game to start with, which is the treatment of the patient. So patient perspectives, values, expectations, and preferences. And these are all viewed with the context of the environment and the organization as well. Very, very different from working in a heavily stressed NHS department to working in a heavily stressed sports department. You know, one is treating patients once every 3 weeks and the other is treating them 3 times a day. Different reasons, different clinical reasoning, different organizational environmental context. And you can't judge somebody else's treatment externally. You know, we should be mindful not to cast our judgment on what other clinicians are doing unless we know that environmental and organizational context in and out, unless you know that patient, unless you know that clinical experience, unless you know that underpinning evidence that that clinician used as well. So we should be mindful of all those things. So when we're putting this through our clinically reasoned funnel, we're thinking N equals 1, the individual patient, those perspectives. What's the pathophysiology and what's the mechanism of the intervention? And also, it's not just needling, it's a multimodal approach. You know, a multifaceted problem is going to require a multimodal address to it to complete it. When we're thinking about needling within this, think about local effects, segmental effects, distal and peripheral effects. We're thinking about what's going on segmentally at the spine. We could be thinking about trigger points, extra techniques. We could even be thinking about traditional Chinese acupuncture techniques, because traditional Chinese medicine, traditional Chinese acupuncture is just observational consensus medicine. That's all it is. Don't be afraid of it. It's just the same thing explained differently. And all this should always be put through this filter of respecting the patient, the anatomy, the technique, until it comes out as our clinical reasoning. So thanks for listening. Rush through some of that physiology for you there, but if anyone's interested in that, you can always get in touch with me. I'll give you the details in a moment. But things to take home from this: analgesic mechanisms can be local, segmental, and supraspinal. It can have myofascial changes to affect pain, dysfunction, and tissue healing. It's safe and effective with the correct training. You know, all adverse events can be avoided pretty much. And we need to respect the client, the anatomy, and the technique. So thanks for listening. That's where you can get hold of me, and we'll hand over some questions now.
Yeah, brilliant. Thanks, John. Yeah, we've had a few questions come through, so I think we'll get straight into it because it'd be great to answer as many as we can do. So yeah, top one is from Ian. It's what are your thoughts on treatment of tendinopathy?
This is a complex one. I suppose, is it a genuine tendinopathy or is it like a radiculopathic tendinopathy? So if it's a genuine tendinopathy, yeah, you know, and by genuine tendinopathy, I mean there's genuine pathological changes in that tissue, as opposed to being like a tendinalgia where it's presenting as pain. The reason I mention this is some pain presentations, some sort of tennis elbows and golfers' elbows and things like that will be caused by myofascial loading, so caused by the loaded tissue. There's a trend in needling to needle the loaded tissue, which is the connective tissue. I tend to needle first the loading tissue. So the tissue that's loading upon that connective tissue, because that connective tissue is passive in a sense. So what is the dynamic structure loaded upon that? And I would needle that before I would needle the loaded tissue. And I would also examine the spinal segment to see if there's a neuropathic dysfunction. And what I mean by that is that if it's an increased loading because of trigger points, that can be a spinally driven thing. So for me, if I'm looking at tendinopathy, I'm looking at spinal segments, I'm looking at loading tissue, and I'm looking at the loaded tissue as well. And as well as, offloading that with exercise or any bracing supports, or whatever in the short term till the problem's resolved. I don't know whether that answers your question, because it depends. It depends how you're viewing like a tendinopathy, whether it is or a real tendinopathy or not.
Yeah. I think some of the other questions just coming in now, just to let you guys know, there's in terms of courses and stuff at the end of this sort of Q&A, we'll just, John, it'd be good to recap in terms of what courses are available and people want to sort of learn more as well, if we don't answer all the questions now.
Yeah, of course.
So Andrew just asked, does the needle thickness gauge, or does a needle thickness / gauge have a greater effect on the connective tissue?
Yes. The thicker the needle, the more tissue it's going to distort. So typically, if you're using something like a 0.25 mil needle, so 1/4 millimeter, that's kind of a happy medium. It's thick enough to be able to insert it into any tissue and get mechanical transduction when you rotate it, but it's also thin enough to be acceptable to the patient. If I'm doing deep spinal needling, so going down through longissimus into multifidus, right down to the articular pillar in the spine, so maybe about that, maybe 30, 40, 50 mil down, depending on the build, I would use a thicker needle. I'd use like a 0.3 needle for that. If I'm needling into the glutes and so on, I'd use like a 0.3 needle to get more effect in that tissue. If I'm needling the face or the head, I'd use like 0.2, because the tissue is much more sensitive in that area. So the short answer is yes, the thicker the needle, the more tissue it's going to pull. But there's a trade-off there about how uncomfortable it is as well. So you need to think about that.
Perfect. And the next one is from Ian Gatt. So in athletes, is there a risk of negative?
Ian.
In athletes, is there a risk of negative impact on performance for long sessions of acupuncture when considering trying to impact supraspinal effects?
Okay, so go on, give me that again. Read that again.
It'll be in the Q&A box if I don't do it justice in terms of
how
you're
fine. You go again.
In athletes, is there a risk of negative impact on performance for long sessions of acupuncture when considering trying to impact supraspinal effects?
Yeah, I suppose there could be. If you're having a longer session of acupuncture and you're getting a suppression of sympathetic response and a stimulation of parasympathetic, you've got to time that, because obviously if you're looking for athletic performance, you want to up the sympathetic response, because you're going to want them fired up, because it's all about that fight or flight preparedness for activity to some degree, not overly, but you're going to want that. I think the thing is with needling, you've got to choose your times before and after training as when you're going to use it. I think of like needling prescription a little bit like exercise. If you think of it that way, you're not going to use a lot of heavy needling before an event in the same way that you're not going to beast your athlete like before an event. On the flip side of that, you're not going to use a lot of relaxing, meditative kind of like yoga type exercise before an event, in the same way that you don't want to probably use a prolonged kind of needling response where you're going to get a descending opioid or parasympathetic response before an event, because that's going to suppress the sympathetic response. So I think that kind of needling I would tend to use after an event, if I wanted someone to relax. Probably shorter sessions like beforehand. I would also be thinking, if I was needling before an event, being a little bit more superficial. So as Ian suggested there, I probably wouldn't leave those in for an extended period if it was before an activity, because I think from a central perspective, it could suppress that upwards drive that you'd want for sympathetic response.
Perfect.
This is the question. He'll text me later if it doesn't.
Yeah. Next one's from Alison. So She says, is acupuncture useful for chemo-induced peripheral neuropathy?
Potentially. Potentially it can be used for any neuropathy, although that's really is a strong precaution. I think there are some caveats there. From a physiological perspective, potentially it could be, but if there are other restrictions as to why you can't needle that patient because of their comorbid state, in the sense that are they immunosuppressed? Is medication causing a problem? Is there a lymphedema and so on in that area? Then potentially that might not be the case. If you're working in a if you're working in that kind of medical unit and you're seeing that sort of patient and you've got it's sort of in a controlled environment, then potentially it's something that you could explore. But you would need to pick your patients and you would need to screen very carefully for contraindications and precautions for that. But physiologically, potentially it could. Whether you would or not would depend on the other comorbid factors and the medication and their how vulnerable they were physiologically, I would suspect.
Cool. And another one here, this is anonymous, but what is your opinion in the length of time needles should be kept in place and stimulated? Is there a benefit to leaving them in for longer periods?
It depends what you're trying to achieve. So if you want the trauma effect, so if you just needle an area for trauma response, you could leave them in 5 to 10 minutes. After they've been in 10 minutes, you're not going to get any more trauma around that needle unless you do something with the needle. So if you're just going to do it for trauma or recovery, then maybe about 10 minutes is fine. If you were needling for sort of trigger points or myofascial effect, that can be seconds or minutes. You can needle, and when you feel the change, you don't necessarily need a twitch response. That's not diagnostic of a change. Well, it is, but if you don't get it, it doesn't mean it hasn't changed. You put the needle in, you find the tightness, you work into the tightness, and then the tightness goes away and you feel the needle's a lot looser. That's done what it's going to do. You can take that out. That can be seconds to minutes. If you want the descending opioid effect, so you want to hit all the layers of the potential analgesic mechanisms, then you perhaps need to leave the needles in for about 20 minutes. Segmental analgesia can occur in minutes as well. So spinal gating can occur in minutes. It's only really the longer standing descending effect. And so it depends, the length of needling time depends on what you're treating, why you're treating it, and what mechanisms you want to get. So it isn't a right or wrong, it's just different. So just to recap, healing responses within minutes, local effects within minutes, segmental analgesia in minutes, and descending opioid effect potentially could be minutes, but in the average, it's probably about 20 minutes.
Cool. And we've got a couple more here, so we've got some good time in, and we can finish off with just going through the courses and stuff. So one from Megan, she says, are there any factors that would indicate a person is not likely to respond to acupuncture treatment for myofascial pain, or is it more likely to be the practitioner's application of acupuncture?
It can be both, 80% of people probably respond to it. From a myofascial perspective, a huge percentage of people respond. Lesser respond due to the opioid effect. One of the problems you've got is if you're using acupuncture from an analgesic perspective, let's say you're treating osteoarthritis in the knee, and it's a fairly static pathology, and you're using needling to create a central opioid effect, and you only treat them, say, 3 times, you may need to treat them more to improve the cumulative response to modify their gene expression. So you couldn't necessarily tell from 2 or 3 sessions if you were relying on the opioid effect and that person didn't have a very high opioid stimulus to start with. It may take them longer. If it's myofascial and it's range of movement, normally as soon as you're in the right place, you'll get a change. So that can often be dependent on, have you diagnosed the problem correctly? Is it what you think it is? And are you where you think you are? That's the other thing. Because I teach anatomy and I teach acupuncture from a very anatomical sense. One of the things I find a lot of times is people are not where they think they are. And it's very important to for safety to be where you think you are. So sometimes it can be that. Sometimes it can be that it's not that problem. And sometimes it can be that the patient doesn't respond to it. But more often than not, they will respond if that's the problem. Sometimes it might not be the problem. And sometimes I use needling to confirm or dismiss a diagnosis. So you can needle to identify and enhance your diagnosis as well. So if the needle's in there and it affects a change, well, that's the problem. If the needle's in the right place and it doesn't affect a change, well, you can stop needling that area because that's probably not going to work, because that's probably not the problem if it's mechanical. So it's a mixture of things. It really depends. You can't lie the blame on the clinician, or you couldn't necessarily lie the blame on the patient, because it will vary depending on the pathology.
Okay, cool. And then one from another anonymous one here. So where do you find acupuncture fits with the treatment of chronic conditions? Do you think it should be avoided due to a possible reliance on passive treatment?
This is an interesting one. So let's put this into perspective. I've been acupuncturing for 22 years, I think. I have no patients addicted to me, not one. I have treated, 60,000 treatments I've done in that time. I have no addicted patients to passive treatment. One of the reasons for that is how you sell whatever you do, and so what I do is I create an exit strategy. From the moment I put a needle in somebody, I'm creating an exit strategy. What I'll explain to them is the acupuncture or the dry needling, whatever we're explaining it as, whatever fits well with that patient. What I'll explain is the needles or the acupuncture is going to help reduce the pain and help them improve the movement, but it's the exercises that are going to resolve the problem. So I'm pitching an active strategy from day one. None of my management of anybody is ever passive, and I would discourage the passive management of anybody. So I know some people may use acupuncture in a passive sense, but I'm always pushing it from an active perspective. For me, it's creating a window of opportunity to access exercise movement, restore function, and that's what's going to resolve the problem, because a mechanical problem requires a mechanical resolution. And so I'm all for a background working in mental health as well. So I'm all for ownership of your problem, lifestyle change, and the positives of exercise, diet, relaxation, modification, all those things. So I do appreciate the question, in that some people may push it as a passive intervention. I would recommend against that. And I would say, create your exit strategy from day one. Before you put the needles in, explain that what you're going to be doing is this is an opportunity to reduce the pain, increase the range of movement, and you're going to exercise along with that. And that's the thing that's going to resolve the problem. So that's my take on it, really.
Brilliant. And then, so Andre's just asked, would you recommend combining dry needling with other physiotherapy techniques like a TENS, laser, or shockwave therapy?
Yeah, it's an interesting one. When you look at the studies, all studies that combine needling with conventional physio, and I'm not sure what conventional physio is sometimes, I'm sure it's like exercise and manual therapy. Depends on the study, but it all shows it improves the outcome for those things. How that compares with, say, like TENS or shockwave, and the shockwave thing is an interesting discussion, because it depends what you're trying to achieve with the shockwave, because if you're trying to create a stimulus to the inflammatory response and the healing response, you can do that with the needle as well. I think it'd be interesting to try and do some research to quantify how much response you get from the shockwave versus how much response you get from the needle, and whether you need to combine that. I mean, I suppose if you were looking at something, if we take a case scenario, let's say you've got a shoulder. Let's say you've got an issue with damage to supraspinatus or rotator cuff anywhere, and you're using shockwave on that tissue. You could then needle things like supraspinatus, infraspinatus, upper traps to increase range of movement and reduce the loading on that tissue. So that would be useful, but you wouldn't be needling where you were shockwaving. You would be needling the tissue that was loading on the damaged tissue to reduce the loading, in a sense. So you could improve function and range of movement. So yes, you could use it in that sense. TENS, yes, what you could do is you could needle And what you notice if you look at TENS machines, if you look at their the manuals that come with them, the location of all the TENS pads are acupuncture points. The reason being is they're not really acupuncture points, they're areas of sensitivity and reactivity. If you want to increase an effect, if you did laser, pressure, electricity, ultrasound, heat, whatever, if you do it over what would be an acupuncture point, you potentially would increase the effect because you're adjacent to neurovascular structures which will respond to that locally and centrally. You're creating an afferent input into a central system. So potentially, yes, you can combine those. You could combine laser after deep needling to reduce down some of the discomfort that's caused by it, and that's done with Chan Gun's IMS system. They laser after needling because it's quite aggressive needling. But yeah, you could do. What you'd need to do is just think about what's the pathophysiology of the problem, what's the mechanism of the modalities, and what are they going to give you and how do they fit together. That would be your clinical reasoning, but they certainly wouldn't be off the table. You could combine them if you could rationalize why. So for me, it might be shockwaving the damaged tissue and then needling the muscle that's loading on that tissue, so offloading the tissue in a sense. So that's how you could use it in that setting. Or TENS after you've needled, send a patient home to reinforce the same points, or laser over needling to reduce down the discomfort of the needling.
Brilliant. I know there's a couple of questions there, but I think for time we'll close there. I think what would be good, there's a few questions and a few comments, obviously thanking you as well, but just knowing if people want to extend their learning, and I know there are courses and stuff, do you just want to give people just quick over? I know you've got a slide here, but do you just want to give people a quick overview?
So if you're a physio, so chartered physio, then I recommend that you get in touch with the AACP. You can find them there. It's the biggest professional network in acupuncture in the UK of any type. Get in touch there. We do foundation courses, and I also teach more advanced courses. So if you're already needle and you're interested in doing some more advanced things, I teach a whole bunch of different CPD courses, deep spinal needling, upper limb management, lower limb management, trigger points, head, neck, face, TMJ, upper cervical, lots of different things if people are interested in those. Also do an anatomy course at Keele Medical School. If anyone's interested in going to that, where we dissect cadavers and put needles in them, you might find that interesting. So if you're physios, check out the AACP. If you're any other medical professional and you're interested in Western medical acupuncture, drop me a note on Instagram. You can find me there under Hobbs Acupuncture. Follow me on there. Go talk about some courses. If you're on LinkedIn, I'm under my name, just Jonathan Hobbs. You can find me on there. So I also run courses for other clinicians who are not physios. The problem is the AACP is we can only teach physios, but I teach all sorts of professionals. So get in touch with me there. I've got other courses that are accredited by other organisations, both foundation level and more advanced. I've got a whole series of more advanced courses that I teach as well in my own kind of like system, which is really just clinically reasoned all the way through on anatomy and physiology. Find me there on Hobbs Acupuncture. If you're interested in something more traditional, so if you're interested in the whole scope of acupuncture, I mentioned earlier traditional Chinese acupuncture, you treat everything in. Check out the North Wales College of Oriental Medicine. The website's there. That's Paul Battersby. He works for the AACP as well. He's been teaching traditional acupuncture degrees for the last 15 years, and he's physio as well. He also teaches some shorter Western medical courses like I do as well, and those have got accreditation with different organisations. So all our stuff is accredited, and we try to offer the best learning experience possible with a broad scope of experience on the course. We try and cover as much of the stuff we can, as you appreciate. Try and give it to you all from a very anatomical and physiological perspective as well, so it fits right into your clinical practice. You haven't got to learn other paradigms, unless you're interested in traditional acupuncture, which is great. My background is in that. Most of the short stuff we teach fits straight into your clinical practice, and you'll go away from there with the confidence and the competence to be able to practice safely and effectively, which is the most important thing.
Brilliant. And we'll chuck those links in the when we send out sort of recording stuff afterwards as well. So just make sure. Follow obviously John on Instagram. His stuff, his thing you can just see there, and LinkedIn, and Yeah, it'd be great just to drop us anything on social as well, feedback and what you've enjoyed from this evening. It's great to see kind of everybody's positive feedback as well. So it's always nice to see. So drop something on social, it'll be much appreciated. But I think we'll leave it there. Thanks again, John. That was a great presentation. Some great feedback, some great questions as well. So yeah,
it's much more interesting if you can see me needle. This is the boring bit. If you see the needling, that's the better bit.
Yeah.
So well, get on a practical course somewhere, guys, and come do some needling with me. It'd be fun.
Brilliant. Cool. Thanks, guys.
Cheers,
And
Charlie. Thanks a lot,
see you
everyone, for
soon.
turning up. Appreciate your time. Thanks.
That's right.